a Japanese man with a 64 millimeter ruptured abdominal aneurysm, which was successfully treated with EVAR with an endurance. And the postoperative course was uneventful. He was discharged on postoperative day 11, and 2 months later, that patient was doing well. And as far as I know, no separate reports from FEVAR for nonagenarians or even centenarians have appeared. Looking closer at the quality of life, there seems to be a significant but transient decline in physical component scores after FEVAR and BVAR for pararenal aneurysms, well, similar to patients treated with EVAR. But patients treated for thoracoabdominal aneurysms, they had lower quality of life scores at baseline, and they didn't show the same recovery after the initial postoperative decline. And when we look at our own cohort of FEVARs between 2002 and 2016, and a minimum follow-up of 5 years, 44 of the 172 patients were still alive at the time we sent them the questionnaire, and 31 sent them back to us. Midterm survival was acceptable with a 5-year survival rate of almost 60%. Death was most often caused by cardiac disease, followed by pulmonary disease. So, as we already know, many deaths of non-vascular origin. Well, quality of life was compared to baseline data demonstrated by the RAND Corporation, and emotional role functioning and well-being. They scored better in the research group, while physical functioning and health change rated worse in the research group. Of all baseline characteristics, only age at the time of surgery was associated with the risk of death during follow-up. And at 5 and 10-year follow-up, 70 and 36% of patients would still be alive for the age group less than 70 years, and 56 and 10% of the patients older than 70 years at the time of operation. Well, also interesting to see is the effect of re-interventions on quality of life. They clearly seem to have a negative correlation with physical component score at all time points measured, but remarkably there were no significant changes in mental scores. So in conclusion, ladies and gentlemen, I believe that age and frailty in itself, they are not reasons to withhold even FEVAR, and the choice of treatment should be based on the patient's comorbidities and preferences. But given the typical life expectancy, careful consideration should be given to the individual cases before undertaking FEVAR in octo or even nonagenarians. And probably most important is value-based care. So to really ask the patient what they want in life and how they want to end up. I thank you for your attention.